Hello, in this session I want to talk a little bit about EMDR modifications for complex trauma. So in a few different sessions in this EMDR series, I've mentioned complex trauma and ways that we can best work with it through, for instance, focusing more on stabilization techniques or integrating target mapping into the process. I want to give some additional recommendations. This is a topic that's been written about extensively, and there are several different protocols that exist that are modifications to the original 8-phase model, and I'm going to include a lot of these in the references section for this EMDR series. Let me give you some recommendations on this. So first of all, with that phase 1, remember I've said this before, that in that target sequence planning phase of EMDR, when you're working with complex trauma, it may be better to actually have the client engage in target mapping as opposed to a more structured target sequence planning. The reason for this is that with complex trauma, most of the time, what we're dealing with is a client who has multiple different, but sometimes overlapping trauma networks. Because by definition, the trauma is extensive, and a lot of times these traumas fall into multiple categories. So when trauma does not fall neatly within one category and it's multiple networks, sometimes it can be very difficult to even define what the presenting problem is. So these clients may say, everything is wrong and everything has always been wrong. So in these scenarios, it can be best to do target mapping where we have the client write down anything and everything that they feel is wrong. Look at these different issues, and from that, we can begin to come up with some themes. We can think of these neural networks as being organized according to different themes, and of course, different negative cognitions with each of these networks. From there, we may also select to do somatic targeting as opposed to using explicit memories as targets if we're getting the sense that a lot of their trauma is pre-verbal, meaning before the age of 3, in which case we're going to use physical sensations as our targets. So that's what I'd recommend for phase 1 of EMDR for complex trauma. But backing up just a little bit, another recommendation I would have is when you're working with complex trauma, consider reversing phases 2 and 1. Okay, so what that means is I'm recommending that you actually emphasize and build resources before you even engage in any sort of target sequence planning or target mapping. The reason for this is that when someone has suffered from complex trauma, it can be overwhelming to even identify these networks, to even identify various targets or to feel into different sensations can feel completely triggering and overwhelming. So you might find that in that phase 1 of EMDR, distress levels skyrocket and they can hardly bear to be in session, even just planning what they're going to do EMDR on. So with these types of clients, I'd recommend focusing on the stabilization first before the target sequence planning. Now that said, of course, when they come in for their intake session, they're going to say a little bit about what's bringing them in. They might go through a rundown of a lot of different traumas they've experienced. Sometimes when you're with these clients, it's almost like they don't want to talk about their traumas, but they really want you to know everything they've been through. And so you can honor that and create some space for that, but then also shift the attention onto resourcing, really focusing on helping them identify or create these different cognitive resources. Okay, so resources for places and then also resources for people, while at the same time helping them learn how to retrain their nervous system to go into the relaxation response using some of those bottom-up techniques such as diaphragmatic breathing or progressive muscle relaxation. So with complex trauma, a lot of EMDR clinicians are going to switch phases 2 and 1, start with that resourcing and preparation phase, and then go into the target sequence planning or the target mapping from there. Now, in terms of how the rest of the phases are impacted when you're working with complex trauma, one big recommendation is to proceed with caution into desensitization. Okay, we want to take this slow and steady. So when we're dealing with single incident trauma and the person is able to stay within that window of tolerance pretty well, then we can dive into desensitization and we can do pretty long iterations of those eye movements or other types of BLS without stopping and checking in. And actually, that's preferable because we know that when we can go a little bit longer with our BLS iterations, it facilitates more and deeper processing, and they can get through that material a little bit faster. But the issue with complex trauma is that they're so easily knocked out of that window of tolerance that we have to be careful about shortening the BLS iteration. So what might this look like? So what it might look like is that the eye movement iterations may last no more than, for instance, 10 or so seconds. And every 10 seconds you stop, and every single time you stop, you check in with that distress level. This is called restricted processing, and sometimes this is referred to as EMD processing. So EMD is restricted processing. EMDR is unrestricted processing. And in unrestricted processing, usually what we're doing is the iterations are longer. Okay, so we're lengthening the BLS iterations with EMDR processing. And when we stop between each iteration and check in with the client, we're usually pretty intentionally vague about what we're asking them. So we might say, "What do you notice now?" And then whatever answer they provide, we'll say, "Okay, let's go with that." And we proceed and we do another iteration. But with EMD, this restricted processing, we want to be careful that the client is not exiting that window of tolerance. So how we do that is we stop frequently, and every time we stop, we ask for that SUDS level or that distress level. Okay, so we ask for that distress level to make sure that they're squarely within that window of tolerance. So another way to think about this is that we're titrating slowly into desensitization in phase 4. So we're reversing phases 2 and 1, and we're entering slowly into desensitization. Another recommendation is to flank that desensitization with resourcing tools on both ends. I said this in a previous session. So make sure they're well resourced before the eye movements and then right after the eye movements as well. As you can tell, a major emphasis with complex trauma is safety and stabilization. This is what we want to prioritize above really anything else. And in fact, there are some EMDR experts that say if you can really do the stabilization piece well, if they can really resource well, sometimes they may not even have to desensitize to traumatic material. Now, some clients will, but there will be some maybe who don't. So this is incredibly important. Now, another recommendation I would have, and this is not really in line with classic EMDR, but I found it to be very helpful for clients. When they get to that phase 5, remember phase 5 in classic EMDR is installation of the positive cognition or integration of the positive cognition. And we think of this as being the time where they've desensitized to that trauma network with that negative cognition. And now what we're doing is we're integrating that network that used to be a trauma network. We're integrating it with more adaptive information, with more adaptive neural networks. So we know what a client's positive cognition is when we ask them, what would you like to think instead when you imagine being stuck on that elevator? Instead of I'm trapped, what would you like to think about yourself when you think about that event? How they answer that question becomes the positive cognition. It too needs to be an I statement, just like the negative cognition. Then what we do is we integrate that positive material by having them hold in their mind the positive cognition. Let's say it's I am free instead of I am trapped. So what they're going to do is they're going to have that thought, I am free, and they're going to combine that in their mind with an image of the worst moment of the trauma. Okay, maybe it's seen an elevator door because they were trapped in an elevator. So they're going to pair these two things in their mind, and what you're going to do is apply slow BLS. Okay, so you're going to slow down those eye movements to install this positive cognition. Now that's classic EMDR. Here's where I deviate a little bit from that. I found it to be very helpful to install multiple positive cognitions in this phase. So in classic EMDR, you just install one positive cognition and you call it a day and you're good to go. But I've actually found it helpful to install multiple positive cognitions if it's the case that they can generate more than one positive cognition. The way that I really see this in terms of neural networks is that whenever we activate a network, the way we can exit it or have other thoughts is by jumping to adjacent networks. Okay? So let's say we have this neural network and it's I am destructive, for example. Okay, so we have this network I am destructive, and maybe it's not a trauma network, which means it's not isolated. It's pretty well integrated with other networks. And let's say that I am destructive has connections to I am bad, and maybe it has connections to I am a failure. But maybe through EMDR, that network also has connections to I am innovative or I am intelligent. If we can connect with multiple positive cognitions, multiple positive networks, then what that allows us to do when that negative network is activated, I am destructive, it gives us more choices for how to get out of that network. The more other networks it's connected to, the more options we have for cognitive restructuring. So when that negative network is activated, I am destructive, I can make the choice to go to I am intelligent, or I am successful, or any other positive cognition. So especially in the case of complex trauma, I'd recommend installing multiple positive cognitions because that provides the client with more ways to get out of that negative network when it becomes activated. So looking at this a little more from a bird's eye view, what we're wanting to do in complex trauma, stabilize, stabilize, stabilize. Reverse those phases 2 and 1. Titrate gently into the exposure piece, the desensitization piece. And extend that phase 5. Consider installing not just one positive cognition, but several. And this is really the best way, I think, to address complex trauma in a way that makes clients feel strong and capable and also safe.